everybody. Sorry, I was a few minutes late. I was drawing in my eyebrows, if I'm honest. They were just rubbing off. And I thought I wouldn't look so crazy. And I just quickly dropped in my eyebrows. And I'm laughing because my husband said, we need to do something about this because it is quite a mess. I am just going to check that I am streaming because I can't see anybody yet. So let me just have a little look. In the group, there's people joining. Hello, everybody. Welcome, welcome, welcome. Thanks, Emma. So I can always rely on you to tell me that things are going good. Right. So we set up with Emma, who is my VA, has been trying to whip us into shape with being a lot better at doing our social media and videos and things. So she's been getting me to send her lots of videos. And also to, in our group, set up when we're doing these events, because then we can start inviting you so that you know that they're happening, so you can come and ask me lots of questions. But I can't do it because I'm a page. So my husband did it, or rather, I did it for him off his Facebook, which we then didn't realise that it sets up this kind of private messenger. So he's had loads of questions from you all day, which we've been really enjoying. But anyway, so I have his phone to answer your questions, and I have the thread. So welcome, everybody. If you are watching, do some little, I don't know, thumbs up or hellos on the likes, because it shows other people that we are here. And I'm going to open these and just try and start. There we go. Right, start at the top. Okay, so let's start with Lydia's. So my 8-month-old reacts to coconut milk through breast milk within 10 minutes of a feed, but she doesn't have the same reaction when I eat things containing coconut oil. Is it safe for me to continue eating things containing coconut oil? And would you think she would be okay having coconut oil directly or not? She has cow's milk protein allergy too, and also reacting to wheat, egg, soya, and potentially beef. And lots of dairy alternatives containing coconut oil. Blimey. Okay, 8 months. Yeah, so coconut is an unusual one to react to through breast milk, I would say. It's not one of the commonest things that we see reacting. And however, you clearly sort of looked like you've tested it a few times and been seeing it's happening. So certainly if you've been having coconut oil and it's fine, I think she could have it. The thing with most of the oils, not sesame oils, but most of the oils, is that they are so refined that they're very unlikely to trigger allergic reactions in people who are allergic. And I assume, but this is an assumption, that the reactions that you're talking about are non-IgEs, where she's maybe getting gut symptoms or worsening reflux, rather than any concern about hives or swelling, and therefore definitely coconut oil. I think then, given that it's a little bit unusual to be reacting, I wonder whether, if we are talking non-IgE rather than IgE, sometimes when I go through these histories, particularly with people that I've got in the membership who seem to have some children who are quite tricky around weaning and these non-IgE responses, we try things directly. So we try something like a very small bit of coconut yogurt, for instance, even just the tip of a teaspoon if you're worried. And we look to see when this is directly going into her body, does she react or not? Was it utterly coincidental? Was there something else going on? But by trying a baby who's now of weaning age directly on some of the foods that you were suspicious of through breast milk, it can really clarify for sure whether there's actually a problem or not, particularly when you feel like the diet is becoming quite limited because of the foods. And I agree with you, even like the formulas often have coconut oils, so like the amino acid formulas. And the reason that they're not declared, so things like soya oil and coconut oil, as an allergen on the formula is because they are so refined, they shouldn't cause problems. But I work a bit with all of the formula companies to give them feedback and sort of expert advice. And we have seen people reporting more issues, but whether it's always hard to know because we haven't got good studies where somebody's like blinded to it, i.e. having the formula and not knowing, you know, because people go into it with a mindset maybe that they're going to react to the oils. So we haven't got good evidence that people should. That's very long-winded, but essentially I would be trying it direct to her to see what the actual issue is. And if she's got multiple restrictions, I hope that you've got an allergy dietitian on board to help you navigate that so that she doesn't drop any height or weight with those restrictions. Hi, Christina, new to the group. My 2-year-old has a cow's milk allergy, and we tried the milk ladder as advised by a dietitian on her second birthday, which was August, but she had quite a bad reaction when we got to step 3. We had to go to the doctor, and they said, come off the milk ladder altogether. Even though she has no milk in the diet at present, she's getting bad eczema flare-ups. We've been prescribed cream as a short-term fix, but can't use it long. Any tips? We use oatmeal Cetraben cream daily. When would you retry the ladder again? Her last reaction was like hives and an eczema flare-up. The questions are always long because you have to give me a backstory, so I understand that. So from the eczema point of view, let's focus on that because we've had quite a lot of people in the group with some really tricky eczemas, and had a little man today, luckily just covered, and it really breaks my heart to see anybody, but particularly children, utterly covered in eczema when perhaps there could be a better path for many if they were just told the right advice. So the first thing I always say is that when people come to me and say that none of the creams work, often it's because people think that creams and the moisturizers or what we call the emollients are going to cure the eczema. And the reality is that we can't cure eczema. There just isn't a magic solution. We are either waiting for their body to figure out what to do with it and stop developing eczema, or we're just trying to find a management strategy that works for that person. And I always say, if you think about it in the same sense of asthma, nobody goes in thinking that they can cure their asthma. They understand that, their child or this adult is going to be on inhalers usually, possibly for life, but certainly often for years, to try to prevent them from getting symptoms. And even despite being on inhalers, you will always know that there might be times you get flare-ups, particularly if you're unwell or the weather changes. And it's exactly the same concept, but for the skin. So really, your moisturizer is just there trying to repair the skin barrier that people have with eczema, which is very dry. So the thicker, greasier ointments tend to be better because they do kind of leave a layer so that the skin stops leaking out so much moisture. So things like Cetraben ointment, Hydromol ointment 50/50. And often people with eczema, the younger ones, if their skin's really broken, prefer them because they tend to have less preservatives in than some of the creams. But if the creams are preferable to you, that's fine. But really, when the skin is inflamed, you really need to be using it more like 4 to 6 times a day rather than just twice a day. Then when it flares up, the first rung of our sort of eczema treatment is always going to be a steroid-based cream. And then we have Protopic, which is a steroid-sparing cream. And then your next step after that is immunosuppressant. There's no kind of thing we're missing or hiding. And the reason that we tried a steroid is that in many ways they, if they're used appropriately, work really well. They don't have long-term issues if you use them appropriately for the right length of time, and they don't suppress the immune system. So they are a good one. But people often are told to use them too thinly and withdraw them or just use them for a week, when really we need to be using them till the skin's clear, and then often weaning off them. So maybe using them every other day, every third day. So I would focus on getting the eczema under control with the right type of steroid and more moisturizer. And then I think, although I don't know the specific situation, it probably wasn't brilliant advice to be stopping the ladder altogether, because if she was tolerating stage 2, I would have gone back to stage 2, treated the eczema, but kept at stage 2. And then we would have looked at, is she ready for the next stage up again in 3 to 6 months' time? If you're describing hives, it suggests to me that this might be an IgE-mediated allergy. And to remind you, and Kathy, yes, you can post the question here as well as on the main bit. The IgE allergies are the ones that give you immediate symptoms, so hives, swelling, vomiting, diarrhea, anaphylaxis. But I would get the eczema better, and then I would start again with stage 1, and I would be hopeful that stage 1 and 2 would be tolerated, and then maybe touch base with us again at that point to see how she's getting on. Hi, Maria. So daughter's nearly 3, hasn't had chickenpox yet, lucky. And so considering about whether or not to get the vaccine because of she's got eczema. She's got multiple food allergies, including unbaked egg, but can't find anything online that says it wouldn't be suitable. what are your thoughts about giving chickenpox vaccinations to atopic children? So I always start with, I gave all of my children the chickenpox vaccination privately, or we sourced it privately. And the reason that we started that pathway was because Ethan had eczema, and because I've seen children with eczema get some quite nasty skin infections when they have chickenpox. And I think also because being a hospital doctor and having spent time working in paediatrics, I've seen children even without allergies and eczema get really horrible chickenpox infections and consequent, complications. So when I was doing paediatrics and had Ethan, I spoke to an immunologist and I said, "What's an immunologist? Yeah. What's your opinion about the chickenpox vaccination?" I was the same as you. I've heard that maybe if they don't have chickenpox themselves, the immunity from the vaccination will get less as time goes on. Is that going to be a worry? Lots of people say it's harmless. Should we just let him have it? And he said, I think we should be offering it routinely in the UK. And I think when you look at the fact that America and Europe offer it routinely, I suspect that a big reason we don't is money, because, all of these things cost money. There isn't good evidence to say they'll lose their immunity to it in the same way with other vaccinations. And actually, I wonder if what happened with many of mine is that they were then exposed to chickenpox and just had the odd one or two vaccines. So it's absolutely safe for children with food allergies to have it. The only reason you couldn't have it is if you were allergic to a constituent, so something within the vaccine itself, so one of the chemicals, which is highly unlikely at 3. So yes, personally, I'm an advocate for having the chickenpox vaccination. It's a live vaccination. It's from 12 months. You need to have 2 of them. And therefore, if you don't know and you've got a younger child, you normally have the measles, mumps, rubella vaccination at age 2. So either you get somebody to do them both on the same day, which is what I did. My poor son had loads. Or you need to leave a month between the vaccinations if they're live before someone can have them. I'm going to can't say for the live. No worries, Sonia. Question is, son's skin prick test at 9 months old was 5 millimeters to milk, and at 2 years was 12 millimeters. Does this mean anything in terms of likelihood to outgrow it? Is his allergy worsening? So I think, first of all, I would say that the size of the skin prick test, as a reminder to everybody, doesn't tell us about the severity of a reaction. So if we know your child has reacted, so you've definitely got an allergy, and the allergy test has confirmed it's present, it doesn't mean the allergy is getting worse, because actually, even with a skin prick test of 3 millimeters, which is positive, that's telling us an allergy is there. And Ethan, when he had anaphylaxis to milk, his skin prick tests were, I think they were around 6 from memory. So they weren't high, because it doesn't tell you that. So we use them to kind of look at tracking of, like, maybe this person, are they outgrowing it? Is it slightly less? Is there any opportunity to introduce baked milk if that's not in the diet? Or does this look low enough that we might be able to move up the milk ladder if you've already started? And so obviously the fact it's gone up makes us go, okay, maybe that doesn't look great. It might be that this is persisting, but we don't really know. And skin prick tests, really, they actually can bounce up and down. And I think it's a bit unfair, really, because we're kind of setting you up for these very disappointing allergy clinics where you're coming and we're like, oh, what's the skin prick? And you've all, put yourself, and you're all worked up for these appointments because they're only once every sort of 1 to 2 or 3 years. And then you go away really disheartened, because it's like any hospital appointment, isn't it? All you hear is what the test is, and then you don't hear anything else. So yes, the fact it's gone to 12 is a bit disappointing, but it doesn't mean at all that it won't come down again. It's just that with it having gone to 12, it makes you think, I wouldn't be introducing baked milk with a skin prick test of 12, whereas anything from 6 millimeters or under, I would have. So back in the earlier days, I would have had a skin prick test of 5. I would have tried baked milk. But some children can't even tolerate it at that level. And in other centres, like, for instance, Leicester up north, where they are much more proactive at trying to get milk into the diet, even with very high skin prick tests, they do have some success, but 12 is very high. So personally, I would feel too uncomfortable about letting somebody do that at home. And in our areas, in the Southampton area, and we have what's called a Wessex Allergy Network group. So we are all the allergists down south for me. We wouldn't agree that the 12 millimeters is okay to be introduced in baked milk. The other thing to give you a bit of hope is that sometimes very young children actually have quite small skin prick tests. So I probably just wouldn't read too much into it, other than to say I wouldn't introduce baked milk at that point. Yeah, the chicken pox. Yeah, I think people just don't talk about it because it's private. And it's a funny old thing when you do NHS medicine, which I do as well. So I'm trying to move my mouth. Is we're told we're not allowed to recommend any private providers. We're not allowed to recommend brands of things. And I just think that really doesn't help people when you come to us as GPs looking for advice. So we don't talk about chickenpox vaccinations much, but I know several colleagues have had theirs done as well. I'm going to move between the questions, but let's do this one. My 14-month-old's on the egg ladder. Currently on homemade pancakes, very nice, which is little egg. Okay, the next step is well-cooked egg, but I'm not sure how long to stay on pancakes for. And might it be worth adding an extra egg in the pancake mix? So I think, like everything, we all have slightly different advice about how we do egg ladders. So I always start with a cake recipe usually, but not very healthy. And it's got 1 egg per, I think it's something like 12 cupcakes, so it's quite a lot. And then we would start small, be introducing that, and then I might do a 2 cupcake recipe, and then I would allow somebody to eat anything from the baked egg. So I use an egg ladder that's got 3 rungs. Baked egg would be things like fresh egg pasta, I think Chewits are in there, Milky Way, all sorts of weird things, all unhealthy things. And it depends on the allergy you're talking about. So for an IgE mediated allergy, then if I had no tests, and sometimes we don't, because allergy centres are more and more saying, if this is just an egg allergy, just manage it yourself and just try baked egg first and then try again in 6 months. So I would normally be looking at moving you up after 3 to 6 months of being happy that person, that little one, is tolerating baked egg really well, lots of things from the baked egg ladder. So I think trying an extra egg, fine, and just using anything baked, stick at that, and then normally that's when we would progress up. And I'm going to just try and Google alongside to put in some hang on a minute. What am I thinking of? It's been a long day. I'll find it in a minute. I'll put the link on afterwards, but there's a website called Wessex Healthier Together, which is actually a paediatric website, but it's been extended across the country because it's such a good website. And on there is a guide under the doctor's section, but anyone can access it, about eggs and introduction and how to move through. So I'll share that on the main group for you afterwards. I wrote earlier this week about my daughter reacting to lentils through dal. Yes, you did. Quite a big hive-like reaction that we saw. So you advised to contact the hospital where we had the skin prick test. So I contacted the secretary, who said they would inform the consultant. Still waiting for a call back. Tonight I made a pasta dish using Emily plant cream. Used before without issue. Only noticed when cleaning away. Oh, this is the bit where Facebook fails me. Hang on. Where? This is the bit with StreamYard. It's really annoying because it cuts the question. So sorry, just bear with me, and I'm just going to use it here. See if I can find it. Probably. It's not come up. I've only got half your question. If you can cut the other, I got to that the main ingredient is ... Still can't see it. Why can't I see it? Can you cut me the other half of the question? If you can type it in there again, I'll be able to see the other bit. That's weird. Oh, I know why. It's because my stream's being a bit slow. The main ingredient is lentil protein. Thank you. Okay. And did she react? Would be the question. So the thing with lentils, it's definitely an allergy we're seeing more and more of, and you can react to one type of lentil and not another. And I don't cook with a lot of lentils. I'm not brilliantly au fait with them, but I know you've got like red lentils, green lentils, pigeon pea lentils, all sorts of different ones. And so if you are a family that use a lot of lentils and your child reacts to them, it can be quite useful to take some of the different lentils to your allergy clinic. Why has that done that? Sorry. And soak them so that we can do a skin prick test by pricking the lentil and pricking the skin. And then we can have a look at whether there are any types of lentils that they react to or don't react to that you might be able to introduce. So I think my question, so no reaction, which is great. So what I would probably look at is, is there any way of working out if the two types of lentils are different? And if so, that's probably what happened. If they're the same type of lentil, then I would cautiously try again with the other food that you made to see whether it's the same issue. But the reason I had told this particular person I'm speaking to is on the membership is that it had a really florid reaction of quite a lot of hives. So it was quite significant. Sometimes when people message me and say, I've tried X and there's just an odd 1 or 2 spots, sometimes we'll say, it's not, I'm not sure. So give the same amount again tomorrow and let's see whether we either get a more convincing reaction or nothing, because sometimes we can be too cautious of saying, oh, stop. And actually you wait a year to see an allergy specialist and then the skin pricks are negative. And it was just a few contact hives. So I would look to see, are the lentils different? And if so, that will be the answer. I've struggled with baked egg because he's also allergic to milk and soy and won't eat cupcake. I know that's the problem with baked egg, that they don't eat the cake as well, which is really like, you think, why wouldn't you eat the cake? It was a big reaction. I bet they're different lentils. So Penny, you know, she's the allergy dietitian on Instagram, and she also often answers for us on the group. She's lovely, and she's one of our expert speakers in the membership. She often gives us lots of different ways that you can try and get baked egg in, particularly when you've got other kind of allergies as well. But one of the ways with baked egg would be fresh egg pasta, because that's got baked egg in it, and that can be quite useful if they like pasta. So perhaps have a little look and see whether that's an option. And I'll see if I can find Penny's Instagram posts where she's given us some other options. I'm aware I need to do both, but I'm just want to go. So I have, my son is 7 with a peanut allergy. Do you know if Palforzia will be more widely available on the NHS in the future? We're in West Sussex. Do I know? I don't know. I can hope. Currently, on the NHS, I believe you've got, I think Cambridge do it. I think Norwich do it, and possibly somewhere in London, and that's it, which is rubbish. But I was speaking with Paul Turner, who's a really good allergist at the Anaphylaxis Business Symposium, and essentially what we were both saying is the biggest problem we have is that doing immunotherapy is really time consuming, and because we just have so few allergists in the country, when we have people who haven't even had their initial assessment yet, to have any of that information about whether they can or can't eat these foods, all that safety advice that all of you know is so important, it's really hard to justify the fact that Palforzia would probably take away. I mean, for instance, when I do an initiation for Palforzia, it takes 3 hours with somebody on a 1-to-1. So for 3 hours on the NHS, that would be 6 people that they could assess. And that's where the challenge lies with it at the moment, that it's so time consuming. So on that symposium, there was a chap from DBV Technologies, and he was talking about immunotherapy using a peanut patch, which is under, I think it's phase 3 trials, which means it's not far off being potentially available. And immunotherapy like that means that if it becomes available and it's NICE approved, so we can have the money to do it, will be much less onerous, because there won't be this updosing where you have to come every 2 weeks, sit with us for an hour, all that labour intensive stuff with a doctor. Your child would just be wearing a patch where they'd be constantly getting a small dose of peanut. And things like that, I think, will mean that change will come through on the NHS, because it will be less labour intensive. So I hope there will be change. I'm not sure, I'm certain. Certainly all the immunotherapy will always, I think, take place at what we call a tertiary centre. So they're an allergy specific centre rather than in an area where a children's paediatrician is got an interest in allergy, but they're not pure allergists. So places like Southampton, the Evelina, I can't think of all the different ones, but ones where you've got Manchester main allergy centres in them. And I don't think it's going to happen anytime soon. I think the NHS is just so broken, and that that really disappoints me. And as you probably know, if you follow us, I do Palforzia and with my colleague Mish Largeness in Southampton. And we are looking that maybe in the future, would we ever be able to offer any different types of immunotherapy? And one of the things that both of us said is it would be really lovely if we were able to run a successful clinic, but that allowed us to have some space to offer some pro bono spaces through for people, because having been an allergy mum, we've still got allergies, but not food allergies. I know that these things are life changing, and I would like to see that we could offer it more, and maybe these are the only ways. As a charity for Anaphylaxis UK, we've also looked at could we fund Palforzia clinics, but again, we go back to the fact that people aren't even getting assessed, and that's where we have the problem with it. It is really frustrating. You mentioned not recommending introducing milk if the skin prick test is around 12, but maybe would under 6. Would that be the same for other allergies? No, it's not quite the same thing. So it's around milk and egg, and the fact that if milk and egg are cooked in a wheat matrix, so baked, then we know that it makes the food less reactive. So some people are able to tolerate it more. And by introducing that baked egg and milk, we hope that will build tolerance, that person then will start to tolerate other forms of milk and egg and outgrow it. There's no ladder that really exists for the other foods, particularly nuts and sesame and that sort of thing. So when we would look to introduce those is either, for most of us, if you've got like quite a rapid drop, so if say the almonds that you were allergic to was 10 and now it's 3, we might really consider, okay, that's not negative, but there's been a huge drop. Is there a possibility of maybe introducing this? But usually it's when they're either 0, 1 or 2, so what we would call essentially negative. And then if that, but what we would have done in my area is if that person had reacted to, say, almond before, and now the skin prick test is 0, 1 or 2, we also quite like a blood test to say, yes, it is definitely negative, because we've been caught out before with skin pricks looking negative, but blood tests being very high. And then we would put them forward for a food challenge, so supervised, to check that you could reintroduce it. And let people introduce things at home if the tests have previously been positive, but somebody had never actually eaten it. So these are just what we call, they were sensitized to it. They had these positive tests and we never really knew what they meant. And now if the tests now look negative, we might say, okay, because they've never actually reacted, I'm happy for you to try that cautiously at home. But usually for foods where there has been a reaction, my practice would be that we do a food challenge. That is not the same across the country. Jaffa cake's any good. I'm assuming, Megan, that you might be talking about the baked egg. Tesco branded dairy free but contain egg. Don't know about soya. That might be worth having a little look. And come back to you, Gemma. I'm just going to answer some of the other questions across here and then on this funny group here. Look, the coffee's gone cold. Oh, Kate Moss. That's a good name, isn't it? Right, Samantha. I have 2 questions for different children. Child 1, age 2, constant flare-up of eczema. I think it's the weather. Probably is. Everybody is flaring at the moment. Using emollients and a barrier cream out in the cold, but I could, but I also find I'm using hydrocortisone too regularly to try and keep it under control. Is there anything else I could be doing? Not really. I mean, it's the constant moisturizer, but the point is this is just a very active time of year when people's eczema are bad. Hydrocortisone is really is very weak, and I really don't have a problem with people being on it for months. I know everybody stresses about the topical steroid withdrawal. It's extremely rare. It's felt that that's only likely to even vaguely be a consideration if you've been on it daily for over a year. And even then, it's still not common. Obviously, we have to worry about other consequences of steroids, which are actually higher on my radar than topical steroid withdrawal, like skin thinning and growth suppression. But hydrocortisone is so unlikely to do that. So I think my question would be, actually, do you need a slightly stronger steroid like Umivate or Adjuvate RD or Betnovate RD? Those are the moderate strengths to really actually make it look completely normal with the barrier creams and teeter that down, and will that bring it under quicker control, possibly? Child 2, nearly 4 months old. Confirmed reactions to dairy and egg through breast milk. I've been free of these for weeks now. What appears to be small patches of eczema, but nothing major. Should I introduce peanuts at 4 months? I'm aware that older brother's eczema didn't really show up badly till 6 months, and older brother has IgE to egg, sesame, hazelnut, non-IgE to milk and soya. Planning to start signing up for the membership when I start weaning. Bless you. Yes. So when people obviously always worry that when you have a first child, I did see your question, Megan, on here. I'm coming to it, but who has allergies? Obviously, you're on heightened awareness, thinking, "Oh my God, is the next one going to be allergic?" And yes, your child does have some increased risk of allergies and eczema and asthma and environmental allergies, but the particular risk is if that child starts showing sign of eczema, that's really when we think, okay, they are at risk. So even if they've only got mild patches, I think if it was mine, I would start with a little bit of veg, and then I would go on to the peanut. And then generally I'm a bit less worried about the egg before, and like immediately. So I try to do that around the 6 month mark, but I do start with the peanut butter. So I would do that personally, because I think, you know, the evidence would suggest that the sooner you can do that around the 4 month mark, the bigger the chance that they won't develop a peanut allergy. And when you're already battling that anyway, you don't want to kick yourself and think, oh, I just should have given a bit of peanut butter. So I think, yeah, start it early, I would. I'm going to come across here, but I'm just wary I'm answering these two. 2.5-year-old, hi Tatum, who has a rash on the back of his arm. Sometimes they become little pus pimples. Trying to figure out whether this could be a food/oil allergy. The reason I say oil is it appears more when you've got vegetable oil, and current allergies: milk, eggs, soya, peanuts, pineapples, and strawberries. We did start the soya lad, got to stage 2, but the rash on his arms appeared, so we cut soya out. Would we need to start back on stage 1? So general rule of ladders is if you were tolerating one stage and it was only stepping up that you start to notice symptoms, try not to go, oh my God, and just give up. Go back to where you were at, because that one was being tolerated. I think what you're describing on the backs of the arms is something that can be perfectly normal and often runs through families. So I don't know if you or dad or anyone in the families has got these raised pimples here, because it can be quite normal. And it's called keratosis pilaris. I'll pop a little link in. Let me try and do that here. There's not a lot you can do about it, to be honest. It tends, oh God, sorry. I'm really failing technology today. It's just one of those things that they have, and it's kind of their makeup, and they can look red and inflamed sometimes, but we generally find that it doesn't particularly bother them. And even when it looks a bit inflamed, it generally isn't really. It just comes and goes. I'm just popping a link here so that you can have a look on the NHS website. Moisturizing it can help a little bit of exfoliation, but generally there's not a lot you can do about it. And I would say that for any rashes like that, or just non-specific like spottiness or even eczema, if you've got no other features like gut symptoms, then it's not likely to be linked to allergy anyway. So hopefully that's okay. Let's come to yours, Megan, because I read it on here. So for people who haven't been in our Q&As or seen Megan's stories before, so Megan's daughter's got a milk allergy, hope you don't mind me sharing, and has been really struggling with airborne reactions at school, which is quite unusual. So don't all panic if you've got babies that haven't started school yet with milk allergy, because it's not super common and certainly not as severe as Megan's has been. So it's meant that she's missed school, and then Megan, you looked, didn't you, in school, I think, the new filter systems and all sorts to really try and help her. But St Thomas's were looking at offering immunotherapy, which again is not something that is uniformly being done across the country at all. So the question around it is that they have their protocol, and this isn't something I've actually seen any other hospital do, including ours. So is so day 1 a 20th of a mil, day 2 2/20ths, day 3 30th, and your daughter, who's I think a teenager, if I'm right, has asked if she could go slower. And I think the answer to that is what? Yeah, I don't see at all why not. You know, ultimately the point of immunotherapy is that we're trying to get the body to be less reactive, to raise somebody's threshold before they start reacting. So it's not a cure, but it's trying to take you from somebody like Megan's daughter who's reacting to just the teeniest amount, to maybe actually if she was accidentally exposed to several mils. And I think you can't remember, you said on here the equivalent is to go up to equivalent of a mil of milk, so that if she was accidentally exposed, she would be less reactive, but also so she could safely drink that amount a day. So it's going to be teeny. So with like Palforzia, which is the peanut peanut immunotherapy, we get them to 2 peanuts by the end of it. And when people come to us, so sometimes we stay on the same dose for a month rather than 2 weeks if somebody's going on holiday. If somebody has had like some tummy aches and it's been a bit tricky, I will stick on it. If someone was super anxious, I'd be perfectly happy to consider whether we just go slower. For us, our mindset would be a little bit, with Palforzia is quite expensive, so we have to think about factoring in that cost. But this is just milk that you're going to be presumably making. So I think I would be perfectly reasonable to go slowly to begin with. And it might be that by doing that, and as hopefully it's going really well and her confidence builds, then she might be happy to step up a bit quicker after that. So I think ask them, but I don't see any reason why they'd say no. I hope that helps. Gemma, so my baby's 6-month-old and seems to have had an instant skin reaction to peanut. Itchy red rash on his face, under his chin and behind his ears. No more serious allergy symptoms. Should I still offer peanut or leave it out? Okay. And for my breastfeeding diet. So usually breastfeeding, it doesn't make a difference in terms of breastfeeding does not normally trigger these IgE reactions, the ones that give you the hives, the swelling, the vomiting. Occasionally, people, when they've given their child the food and it's become apparent they're allergic, have been able to go, do you know what? When I was eating peanut, I found that they were always really unsettled, or actually their eczema always died, and they can sometimes make some correlations. But on the whole, it's absolutely fine. So if you're fine eating, if you haven't noticed any symptoms, you're fine to eat it. My word of caution from having made these mistakes myself is make sure that if you're eating peanuts, you wash your hands and your mouth before you kiss, because otherwise you can have contact reactions from kissing. Done that. And yeah, just be mindful of the handling around baby. If you gave the peanut and there was quite a lot of rash, then I would say that really they need a skin test to just confirm that it was a problem. I wouldn't keep offering it. They need to have an allergy test to show, is this a problem? And if it is, then it needs to be kept out. Whilst you only had hives, I'm assuming, it doesn't mean that if it was given again, it couldn't be a more serious reaction, because we can never quite predict it. We do know the smaller ones are less likely to have really awful reactions, but it can happen. So if you've got a clear history where I gave peanuts and there was quite obvious rash and hives, I wouldn't give it again. I did have a mum reach out to see me who I'd seen their child privately and they'd reacted to peanut and had a positive test. And then we'd referred them into the NHS system for like the longer term follow-up. And when they were then seen a year later, the test was all negative and they're eating peanuts fine. So sometimes it can be transient, but you need to be mindful that we have to do things that are safe. And it sounds to me that babe can't tolerate peanuts. Why do some foods take longer, sometimes years, to sensitize the immune system and cause an allergic reaction? Is there any way to see this coming? No. We just don't know. I suppose it's in the same sense that why do people lose tolerance to drugs? So, for instance, like medications like antibiotics, you're generally not allergic to antibiotics the very first time you have them. It's with second or subsequent causes, not super common with little ones, more common for adults. Happens in anyone, not people with an allergic type history. And why? Like, why do our immune systems suddenly go, oh yeah, actually, that's a bit of a threat to us and we're going to start causing a reaction? We've no idea really why our immune systems have gone so completely haywire, because the whole point of us having these IgE cells, this immunoglobulin E, was to fight a parasite infection. So if we had parasites, we would sneeze, have diarrhea, vomit, and get rid of them from our body. But what we just don't understand with evolution is why has it changed, and why has it changed for some? So you're not likely to suddenly become allergic to foods if you've got no allergic background, so no eczema, no asthma. It'd be very unusual for a 50-year-old to suddenly develop an allergy. And most of the allergic reactions for people are going to be figured out in the very early days, so like around weaning, on these first few exposures, it's not super common that people will have been eating foods regularly and then become allergic to it. It tends to be more that if you have like gaps, and this is why we talk about it's good to eat things regularly, but then again, the evidence doesn't support that you do need to eat things like sesame every week. We don't have any data saying it definitely do, but what we see is that when people eat like cashews but don't eat them again for a few years, it can sometimes be in that intervening time they lose tolerance, and then the next time they start reacting. We just don't know why. So what can you do? Well, I suppose you always try and keep the allergens in the diet, but I'm not one to try to medicalize eating. I think we're just unlucky that these things happen, and we just don't know why. If we had the answers, we'd be able to turn something off, I think, or try to figure it out. Went to the doctor with my atopic teenager as she had a respiratory infection, was out of breath. Oh, this is another one where it's half a question. I'm going to be able to get to this happened many times, so if you can copy me the other half, that would be great. Checked over, told it was a virus, and to rest. Then that evening, very unwell, struggling to breathe. A couple of puffs of inhaler didn't work. Heart rate, breathing rate increased. Gave 10 puffs of the inhaler, and after 20 minutes, she started to feel better. This has happened many times where we've ended up in... I think you've put it on here. Let me have a look back. I'm going to struggle today to get through all your questions. Good. Try and see your other half, sorry. There we go. Where it's happened many times where we've ended up in hospital. Is there any way to prevent it, sorry. So yeah, so I think I would be looking at what's going on here in terms of, I'm assuming we're talking about somebody who's got asthma. And if you're finding that every single time that person is getting a virus, that her asthma is flaring up and then she's getting really wheezy, then it suggests to me that we haven't got a good management strategy in place. So what are we going to do when she's got asthma? So we are switching quite a lot of people onto these combination inhalers if she's not on it already. So it's a combination of a steroid with like a long-acting blue, the ones that open up and dilate out the airway. Because what we know is that people often aren't brilliant at managing their asthma. And I know, because I say, what inhalers do you on? And they always say the blue one. And they forget to mention the preventer, which often is brown, but these days are different colours. And what that tells me is that people aren't always very good at taking it regularly. So what the evidence has shown is if you switch them onto these mixed inhalers, which have got a long-acting blue and the brown components of the steroid, and then you tell people that when you're feeling wheezy, take an extra puff of your regular inhaler, which is this combination one. That gives them an extra little boost of steroid, and we know that they're compliant, so their ability then, willingness to take that inhaler is better because they get immediate relief from it. So all of us are human. When we take something and it works immediately, we want to take it, so they take it regularly. That means that they're constantly getting these bits of steroids, which will work on the lungs by treating the inflammation, opening up the airways, and that's fundamentally what you want with asthma. So then I would have a pathway in place with her that as soon as she starts to get a cold, she starts increasing the amount of that regular inhaler that she takes. So normally it'd be 2 puffs twice a day. I think you can go up to 8 a day. So I'd be saying maybe take 2 extra at lunchtime. And that then will start, basically, instead of having to need oral steroids all the time or frequent admissions, we'll start treating the lungs early during these viruses so that hopefully you won't keep getting to crisis point. So basically, she needs an asthma review with her asthma nurse, and I would ask them about combination inhalers. And the other thing that is worth doing is making sure that somebody's had a look at what are her environmental allergies and making sure they're well controlled. So that can be worth a blood test to have a look at an environmental panel, which GPs can do, which would look at their house dust mite, cat dog, grass pollen, tree pollen, moulds. And if she's positive for those, you can look at, can we minimise them? But if she's getting a lot of sneezing and congestion day to day, if you then add in maybe like a steroid nasal spray, which is very safe long term, that will treat here, and that often brings the lower airways under better control. So she needs a good old review. And really the fact that you're having multiple times that you're having to go into hospital tells me that somebody's not looking properly, and they should be. In the milk ladder, where does butter fall? I think it depends on which milk ladders you're following, frustratingly, because there are different versions. But generally, you start with baked milk-like biscuits, and then you go on to muffins. And so it usually sits at around step 3 to 4. Forgive me for not being perfect, but it's slightly higher up than the baked. But it's not super high like yogurts or cheeses. Only day 1 in hospital. Megan's referring to her immunotherapy. Yeah, I know. And I think she'll feel nervous, and I totally get that. So I would go slowly. Rachel, did I answer your question? I can't remember. I'm moving between. Have I answered your question? No. Where's your question? Oh, there we go. Oh, good timing, Rachel, because no, I'm just about to do it. We went to a play cafe this week, and my little girl had an allergic reaction after putting a trolley handle toy into her mouth. Kids. She had hives around her mouth and sniffing and snorting like a piglet, bless her. The hives went after wiping, but then she had a second set appear. The snorting got a bit worse, so we gave Puriton. Would you say in this case she was having symptoms of anaphylaxis, and did I treat her correctly? She's got multiple allergies. And then you asked me another question. It's difficult to know when I'm not there. So I think, so the signs of anaphylaxis for people, so airway issues, so constant coughing, it often sounds a bit throat clear. It's like the voice going really croaky, or tongue swelling or dribbling, breathing difficulties, going really floppy and quiet, or collapsing. So I think if she was really snorty, if it was like, if you think it was a bit like she might sound if she had a cold and her airways were a bit blocked, it could have been because you get more congestion when you're exposed to the food you're allergic to. If it was grunty, like where there's often, that hurts my throat, airway issues, and that noise doesn't tend to appear with anaphylaxis because that would imply real narrowing. That's where someone's trying to push their pressure off. So if it was grunty, then I would have given an EpiPen. If it was more of a really snotty, congested, like I've got a cold, I think it would be reasonable to give antihistamine, watch for 15 minutes or so, making sure it's not getting any worse, and then see how things go. On that, I'll refer to a question that I saw come across the this weird messaging group that we've set up and probably opened ourselves to gazillions of questions, because now I feel like I have to answer them all. Someone asked me, why is there variation between countries as to when we should use adrenaline? And I think that, I don't really know why is there variation. Unfortunately, we all, in different countries, we often treat different conditions in slightly different ways. If you even look at the definition of anaphylaxis, it's different from society to society. So there are different societies like British Society of Allergy, and then you can look at different journals that have a different reference for it. So given that people can't even agree on a definition, it's not really any surprise that they're not agreeing on exactly when do you use adrenaline. So in America, they, I believe, recommend that they give the adrenaline, their EpiPen, if they have 2 or more symptoms of allergy, so hives and swelling, and they would give it. And I asked my colleague about that and said, gosh, America are really reactive in giving EpiPens. And he said their death rate is no different from ours. And so that made me sort of reflect of, actually, if I think about my son's situation, he unfortunately had quite a lot of reactions to milk, because just like your little one, Rachel, milk was all in play groups. He would always put things in his mouth. And also the food labelling laws 14 years ago were different, and I was rubbish, and it didn't ever, in fact, no one taught me how to read a label or tell me all the different ways and names that milk might have. And so I made lots of mistakes. And his reactions would always be hives and swelling. And he would have been EpiPenned so many times, I think it would have been very traumatic. And if it doesn't actually make any difference, I feel that it's not the right approach. So I think I feel comfortable with the way that we go in the UK, particularly also knowing that many people don't even use their EpiPens at a time that they have anaphylaxis, or health professionals don't recognise it. Paramedics reassure you, A&E reassure you when they should have been doing it. And I'm guilty of that because I didn't realise the first time Ethan had anaphylaxis. And most of the time people get better. And part of that is probably that we produce adrenaline when we're stressed. Obviously, we never want to risk it. And we know that the timelier intervention, the better. That if you can give it in the first half an hour, you're much likely to make a better response. So, that's why I say maybe wait 10, 15 minutes. But if things were ever getting worse, just give it. Because actually, as anyone who has allergies will tell you, if they're having an allergic reaction when they have that adrenaline, it makes them feel better just like that. And that's often a defining way of knowing it's anaphylaxis or an allergic reaction versus an anxiety reaction that some people also start getting muddled into the mix. So I don't know why the difference is, but I can tell you that, it doesn't make any difference to the ultimate outcome, which is the thing that we all fear that is very rare. And therefore, I think, given it's quite stressful as parents to be giving EpiPens and Jex pens, but also for the person themselves, I think choosing the right time is probably better, but also it never hurts. So for instance, Rachel, if you were at a point of going, oh, I don't know, just give it. It doesn't matter. They'll feel better. And I spoke to somebody on the membership call the other week, and they'd been left feeling like, after their appointment, a little bit upset because their consultant had been a bit like, maybe it wasn't anaphylaxis, when I really feel it clearly was. And I just don't think those conversations are very helpful. I can say with you afterwards, like, I'm not certain it was because of X, Y, and Z. However, I will always follow that up with, however, it just doesn't matter. Give it. And there's, I work with a few campaigns to be sharing the safety of adrenaline. And then we have allergists sat in the room and we all say the same thing. If it just doesn't matter, give it. So if in doubt, give it. What was the other half of your question? I explained what had happened to nursery, and she went the next day. Little girl moving from baby room to nursery, moving up. They were surprised about what had happened and explained there's a snack self-selection at tea time, and they all, at every meal, sit on chairs at the table rather than high chairs. They asked what I want my little girl to do, whether to be in a high chair away from the table and other children's plates, or not, or rather at a table. I don't want her to be excluded. Oh, they need to rethink their policies. This is what my little man had too, and I wish, like, in hindsight, that I know I might seem quite mouthy, but I always say, like, in certain situations, I find it quite difficult to advocate, although I think I've got better with age of having had more children, and, he's 14 now. But back at the time, they used to put my child on a separate table at nursery, and I always hated it because I just felt it was completely discriminatory, and I just kind of went, okay, well, and lived with it. And it was mean, and it's not needed. And there are many, many nurseries that do amazing, incredible things to be completely inclusive. And we wouldn't have somebody else with a health condition that we recognise more, like, and apologies because I can't think of a good example, but somebody in a wheelchair, and for whatever reason, we wouldn't just shove them in the corner and think that that's acceptable. To not be inclusive. We are, bright people. There are ways of making it. So, there are some nurseries who will have different coloured cutlery and plates and cups to make sure that child's food groups are always identified to keep them safe. If it's a self-selection, that's fine. However, this is a baby of 15 months. They are still very little. They obviously can't make the right choices. And the allergen shouldn't be freely there for them to be able to get hold of. It's just not acceptable. Children can have hugely significant reactions. We've all seen the horror stories of things that can occur. So I would be asking to meet with that manager, and I would be talking about the fact that you need to be inclusive, but we need to also be keeping my child safe because she could have life-threatening reactions. How are you going to do that? And I think as one of the mums kindly made like a checklist of different things about conversations to have with nurseries and to make sure we've all checked it. And that expert talk we did a while ago that was all about schools gave really good tips about how to navigate that as well, if you haven't listened to it. But I'll try and find the checklist and put it up for a link so people can access it if they want to and have a look. And maybe other parents can tell you about what they've done on maybe start a strand on the main group about what does their nursery do to keep their child safe, because some of them are brilliant, including getting the children to avoid all of those foods and have alternatives. And I know that your child's got multiple, but there are ways around it. I'm going to do these. I've got two here, and then I'll come to you guys across here. Laura, I've been told I'm I can always tell you're usually American because you use the word ana, which we don't usually use so much in the UK. Or maybe you're not, I'm just studying. But anyway, anaphylactic to tree nuts, food challenge to follow for peanuts. I'm worried about hand lotion, shampoos, etc., and whether they contain anything I react to. I really want to have a spa day, but worried about almond oil, and I want to just enjoy normal life things. I get that. And it's really very hard because nobody kind of comes out and says this is completely safe, and that's really the difficulty, because we're left going, I'm not sure. So in a clinic setting, I would usually say that, again, the oils for these products are usually very refined and not likely to trigger reactions. Contact reactions that can then trigger a more widespread reaction like anaphylaxis can occur. So if you have a child or anybody but allergic to something and it goes on their skin, it can be that it can then start triggering a more, what we would call systemic reaction. So hives, vomit, a more widespread reaction rather than just hives at the skin. But it isn't very common. And often some of the reasons that like, for instance, there was a big uproar a while ago with sun cream with Nivea that it had almond oil, and people were sharing the rounds about, oh my God, Nivea now has almond oil. And actually it had been there for a little while. And when you look back to Nivea, they had made a post saying the reason that we didn't declare it is because the almond oil is so refined, we don't have to declare it as a food product because it's not likely to trigger a reaction. And that is right, to be honest, that these oils are usually so refined in medications and the product that they are not likely to trigger reactions. But it's just always very difficult because it's sometimes you can never say never. And sometimes, especially on the huge platform that we have of social media and the internet these days, you often can have people sharing stories of how something happened to them, but we never then know the individual circumstances because, of course, we're not their doctors and we don't have their health records, so we don't really know, was it that or what went on in that situation. So on the whole, they're fine. I know, like when Ethan was little, we had an Elemis bath. It was an Elemis milk bath, and I was in it, and it just got in with me, and he came out in hives. But again, looking back at it, I was thinking, I don't know, because now I don't know. It said Elemis milk bath? Does that actually contain milk? I don't know. Was it just the heat that triggered hives? So I can't say definitely never, but it really is very unlikely. And I shared a link through the other day, and that's why they're not all written in bold. And I think that's also, like, people like you guys, you're on an active group about allergies, so you're really exploring and you're wanting to learn more and you're finding out and you're sharing information. But the vast majority of people who have allergies don't actually, they just go away from their clinic and they go on and try and figure out, often struggling because they haven't got the support that we all have. And so nobody would cross their mind to start checking products. And we are not hearing left, right, and centre of people reacting to all these creams and lotions and medications with refined oils. And I think that's because it doesn't happen. It's really, really very, very unlikely. So I think I would go and have a massage. I think that's highly unlikely that anything is going to happen. And I could be wrong, and I'll reach out to another colleague I know who knows very intricately all of the deaths, but I don't think there's ever been a death reported from those types of things either. And I think that's all the assurance I can give you. It's highly, highly, highly unlikely, but it's very difficult without lots of studies into it to ever give you 100% guarantee. That I think that's the best I could do, that most people are not likely to react. But I totally get why you're, and I think the other thing I would say is that sharing awareness about how creams and oils and things have nuts in makes a good social media post when you are looking for some content. And so sometimes I've seen things that might be well-meaning, but sometimes actually just create more anxiety when there's not really good science that you're going to start reacting to it. And so when I have patients in clinic, I don't warn them about all the products and stuff, or to go and check all those packets, because they're not likely to happen. I hope that gives you a little bit of assurance. It is a really tricky one. It's a bit like lactose in medications with a milk allergy. Nobody's come out and said it's absolutely fine, but as allergists in clinic, we'll tell you it's fine, because the lactose is it's a sugar. It's medical grade lactose. Is highly, highly, highly unlikely to be contaminated with milk. and therefore for pretty much all milk allergy sufferers, they're not going to have a problem with it. But yeah. Oh, George is on the phone. I'm not going to answer you, George. I will. 2 ticks I need to give this to my husband. Gareth, George on the phone. I'll leave it there. Sorry. That's because I haven't got to hubby's questions. Oh, Ish, you've written me a long one. Okay. Thanks for the invite. Questions. So I'm 55 and anaphylactic to peanut and tree nuts. Had my first severe fatal reaction just over a year ago, which resulted in anaphylactic shock and near fatal. I've got used to the adjustments, thank you, and way of life, but I still wonder about airborne reactions, as I had a reaction recently waiting in the job centre where the advisor was munching on nuts, started to feel unwell, and within 15 to 20 minutes wasn't able to drive. Total collapse, called ambulance, didn't use EpiPens because no swelling, but short of breath, nausea and impending doom. After speaking to an allergist, she said airborne reactions are not a thing and that the only way to have a reaction is through touching it. I'm confused because it felt awful, and lots of people were saying they react to airborne, and I have itching and prickling skin when I walk into supermarkets. So in short, is having an airborne reaction to nuts, in your opinion, or a reality or a scientific impossibility? This, again, goes back to the fact that when people come onto social media groups saying, I'm airborne to X, Y, and Z, we have not sat down with them to understand what was the situation there. And also because we're not actually ever going to be there to be able to know, like, if we were to, I don't know, swab that environment, was it that food and the contact of what you're allergic to was in the environment, or was there something else going on? So when somebody says something online, we never really know their situation of actually what went on. There's not lots of studies around it, is the reality. So do I think it's a scientific impossibility? No, because I definitely think there are people who are saying things. And actually, you can have airborne reactions, and that's particularly likely to fish and milk and egg sometimes when it's cooked. And those are the 3 commonest things that I've seen it to. And it's felt that nuts are less likely to become airborne and aerosolized to be able to trigger reactions. And people quote a study, but it's just not a brilliant study where I think they did make it. I think they, I can't remember the details of it. There was some sort of study where they looked into the likelihood of it being airborne and felt it wasn't likely. But I don't think there's good enough studies for us to say categorically that can't happen. But there are other studies that show things like, there was a study where they used peanut butter on one chopping board, only on this chopping board, and then they checked dust throughout the house and they saw that it contained traces of peanut everywhere. So we do know that, food residue can spread everywhere, and for some people that then may be enough to trigger reactions. And we think that particularly is what's most likely to be happening on planes. That, it just seems like the British public don't eat a lot of nuts until you get on a plane, and then suddenly everyone wants to eat them. And so we think the residues are there, and that's why people react. I think one of my thoughts around what you're saying there is, and we won't know, is a reality, but is there any possibility that some of it is around anxiety? Because when you listen to Dr. Francesca, who's our clinical psychologist, talk, but even if you start looking into what does anxiety look like and what does anaphylaxis look like, they are almost identical in the symptoms that would present. So you will get feeling of doom, race of your heart rate. If we actually checked, if your blood pressure was going up, that would fit with anxiety versus anaphylaxis, where your blood pressure would drop. And that's what the word shock means. When you drop your blood pressure, you can start feeling nauseous. Because, if you think about, well, many of us think about when we're feeling stressed and anxious about exams or something we're het up about, those anxiety symptoms are the exact description of anaphylaxis too. And I always tell some of my patients that in a study where they were looking at penicillin allergies and whether someone was still allergic or not, the first dose that they gave everybody was a placebo, i.e. not penicillin, and 25% of people got hives. So the stress of it can trigger hives. But I noted that you said that there specifically wasn't those features present. So it just may be that, you're already in an anxious situation of going and trying to sort out jobs and that stress. And there's someone right in front of you who's eating shed loads of stuff. I wonder whether it was that, but I'm not saying it definitely was. If it was anaphylaxis, what we might see, and not always, is that there's a marker called the tryptase that would go up, but of course you need somebody to then take it for you. The walking past the bakeries and stuff, I think is really, really highly unlikely that that's triggering it. And I think it's the anxiety and the trauma that you probably feel still because you had such an awful anaphylactic reaction in the beginning. So is it any wonder when something nearly killed you that your body, whether you're aware of it or not, is creating this response? It's basically the fight or flight response, isn't it? That you know that you've got that memory that this nearly killed me. No wonder it's triggering symptoms. So I wonder in your specific situation if that's what might be going on. Do I think it's a scientific impossibility for things to be airborne? No, I don't. Okay. Oh no, okay. My sons haven't been picked up. So I hope that helps. And yeah, I mean, most of the work we do with Dr. Francesca is around children's. She's a children's psychologist, but I put on the group before, you know, is there an interest if we start doing a membership for adults? Because I've had quite a few people reach out to me, and so I have a psychologist who works with adults who would potentially then come and work with us. And what basically Dr. Francesca does in the membership is she comes on every month and she answers people's questions, but she starts trying to give them strategies about how to restore and reprocess really and work through the trauma of what happened to you. So she talks about it, and forgive me, I'm not a psychologist, but she talks a bit about it like a filing cabinet, that we all have these memories, and when we've had these traumatic events happen to us, that we do need to re-examine them. And it can be really good then to focus on all of the what went well. So what went well? I'm alive. But also, what were there aspects through it that were things that you can reprocess of what went well, so that you can try and store it in a better way to be able to work through the trauma that it gave you. And so our psychologists work with our families to do some of those things. So the adult membership, I am looking at it. I'm hesitant because adults are complicated. But anyway, we'd have an adult psychologist, an adult dietitian, and me trying to support you guys through. So keep your eye out. I'm looking at it. I do have some adults in the main membership, which is open to anybody. So you're welcome to join and listen to Dr. Francesca because the strategies are still the same. But yeah, also I've got lots on these next couple of months. So I'm mindful that I tend to take on too much, if you haven't guessed. Right, got delayed by bedtime. Don't worry, I should be doing bedtime, but they're having a whale of a time out there. My daughter's had cow's milk allergy, had hives. No, I don't think mine's. Had a hives reaction when I tried milk ladder, muffin stage 2. Oh no, I did answer your question, and it was. And if you look back at the very beginning, that spent the very beginning section talking about how you could manage the eczema first, and then definitely restart it. And is she something she will outgrow? She's only 2, so I would say the fact that you were on stage 2 of the ladder successfully and she was tolerating it would be a really good sign that yes, she should outgrow it. If you can get baked milk in. So signs that you're likely to outgrow a milk allergy would be that you don't have anaphylaxis the first time you have it, and that you can tolerate baked milk early. Those are good signs that somebody should outgrow it. Kathy. I can only see half people crossing. So again, just so the other people of the group don't know if they don't read all the questions. So Kathy, you've been talking about how you've got really tricky respiratory symptoms and environmental allergies, and you feel that much of your respiratory symptoms are because of the environmental triggers, and you've been asking me on the group, could you have immunotherapy to try to desensitize you from some of these environmental allergies, and then might it give you better control of your respiratory symptoms? And I'd said to you, and so it might apply for others, that when we're considering immunotherapy for anything, actually even food, the key thing is that somebody's asthma has to be good, because when you're being given the thing you're allergic to, then it could really start triggering more reactions, including anaphylaxis, even if we're giving you for house dust mite or pollens. And if your asthma is quite severe, it precludes you from having it and the immunotherapy because of that risk. And so I'm very atopic, always sneezing, runny nose, it all stopped. And now when I come across airborne allergies, I'm getting tight chested, thick nasal drip. rasping in the throat, and it's harder than ever to breathe. And I'm sorry, because the computer does only let me see half. Let me go to it. I always spell anaphylaxis wrong too, Laura. Don't worry. I have to go back and type it properly. I can never see it. Can you type me the other half of your question? Kathy, I've got to. I'm not sure if it's asthma, if my peak flow never drops, heart rate, etc. I mean, already what you're describing to me there sounds like it's environmental. And I think we've talked before, because what I would normally say is the best nasal type spray that we've got is one called Dymista, that's licensed from age 12. It's a combination of a nasal spray, steroid and antihistamine. That's brilliant. And then adding in antihistamines, and sometimes Montelukast medicine works well. And I've got a feeling you've tried all of those. So I do think you'd be a good candidate for the environmental. And it would just depend on what your meds are. So if you're on like steroid inhalers, that would probably be fine, especially if you've got normal spirometry, so the lung test and peak flow, then I would probably not be saying you can't have it. But it would be ideal if you could be doing that in a hospital setting where they can really keep a close eye on you whilst your respiratory symptoms are a bit dodgy. Off to bed. Yeah, we will save it, don't worry. I'll see whether you've typed me the other half of the question. Get her bloods done. Yeah, put down. Any advice on trying my little one 20 months with peanut butter? Non-IgE to milk and soya, potentially IgE to pea. Okay. When I ate large quantity, but she ate it very early on, has had a hive reaction when I ate a large quantity of peanuts breastfeeding recently. Eating small, she's itchy but no hives. Okay. So, again, if people don't know, and I never did, peanut is a legume, not a nut. And obviously peas are also a legume. And there's the potential from what you're saying that maybe she is being reactive to peanuts when you're having it. And so you can try it by all means. And I would be trying it super, super cautiously. So I would do a dot of peanut butter straight into her mouth and nothing more. And I would look and see what happens. And then an hour later, I'd do just the tip of a teaspoon and see what happens. And if you start getting multiple hives, give her some antihistamine and that's out, and she'll need some skin prick tests. If it's fine, the next day I do a quarter of a teaspoon, half, 3/4, and you're aiming for a heaped teaspoon. I'm a little bit suspicious from what you've said, but that she might react. So the other option is if you are under an allergy clinic and you've got like soon appointments, you could ask them to skin prick test peanut, given that she's pea allergic and there's a possibility of already having reactions. But if you're going to do it super slow, and then hopefully all you'd see is hives if she's reacting. I feel concerned we still don't have an EpiPen despite these strong reactions, even though she didn't actually eat the food. So Rachel, remembering that, sorry, what the dogs? Come on, doggies. Yes, Daddy went out. I think you have a good argument there, Rachel, to speak to your allergy clinic and say, you know, she's got multiple allergies. And okay, we normally give the guidelines for when you have EpiPens and Jex pens is if you've had anaphylaxis or if you've got asthma. We know that people are higher risk of having anaphylaxis, but they are just a guide. And my argument, if you want to try and push it through, is I would say to them, I'm aware 50% of people who have died from anaphylaxis, be it very, very uncommon, 20 to 30 deaths a year from all causes, so really, really, really rare, were in people who were told their reactions were mild. Given my daughter has multiple IgE allergies that I know the chances of outgrowing are around 20%, and I'm concerned about these reactions just even to small amounts, I really would feel that she should have an EpiPen. And I think that would be a very hard argument to say no to, personally, and I would give you them. And I know that our hospital in Southampton would have given you them if you'd come and spoke to us like that, and particularly given that she's got multiple. And I think given that there's so much variation, I genuinely feel like that's absolutely fine. You can always have a consult with me. I can prescribe them privately. The challenge is they cost £35 each. You need 2. So it's £70. But again, you're welcome to do that if you felt that you wanted to do that, because that would make you feel secure. I'm happy to do that. I don't have a problem with people having EpiPens. I think we're quite cost driven, if I'm honest. Megan, have you ever had anyone's blood skin prick test too high to attempt immunotherapy? No, it's not. It's not a level that we look at to say, no, you can't have it. And again, it goes back to the fact that you can't predict severity of reactions based on their IgE. So who would we wouldn't do it for people if their asthma is utterly unstable. We would we would make sure that their asthma is 100% controlled before we even vaguely go near somebody having food immunotherapy. But the blood test number doesn't mean anything to us. And then we're mindful. And I know, like in London, where they do much more immunotherapy privately, if child's had anaphylaxis or they're asthmatic, particularly someone like your daughter, would be doing all the dosing in a hospital. And sometimes they do the lower risk, so the younger children or non-asthmatics, no anaphylaxis previously, in a community clinic setting. And I always say to families when they're like super anxious around weaning that when it comes to infants, it's the safest time to be trying and giving all of these different foods. So it seems a really bizarre thing because in every other health condition, when it comes to babies, they're really vulnerable. We know, they're very vulnerable with infections, all sorts. And yet with allergies, it's kind of the safer age to be giving it to them as opposed to our teenagers who become higher risk. So that's why I'm so proactive in trying to say, let's try babies on peanuts, on the egg, on the tree nuts, particularly where there's risks of anaphylaxis, because it's the safest time to do it. Alternaria and cross-reactivity to mushrooms, spinach. Can I elaborate? Oh God, I don't know if I can. So well, probably. So and somebody asked me about chicken and fish on that thing. Hubby's had to take his phone now, so sorry. I'll come to those questions later. So sometimes the proteins of various things that we can be allergic to appear in other foods. So, for instance, when people have a birch pollen allergy, particularly, half of those people react to fruits and vegetables and some nuts when they're eaten raw. So it's really common that people will say, when I have an apple, I get a really itchy mouth. And it's because the protein in raw apple looks really similar to the protein of pollen. And sometimes you'll have a positive test at apple and sometimes you don't. It's a bit hit and miss. When you cook apple, it changes how the protein now looks and the body doesn't react. So you can eat apple juice, apple crumble, and you get no symptoms because they're not truly apple allergic. But in the raw form, your body's basically going, why are you eating pollen? So I suspect that with Alternaria, there's probably, and I didn't know specifically about it, because actually we don't see loads of those people with mold allergy, but probably what you're describing is the same concept, and it's called pollen food syndrome. But it will be that I suspect that Alternaria mold looks very similar to mushrooms and spinach raw, but I can't guarantee it, but I think this is what you're talking about. So in its raw form, you might find you get an itchy mouth, but if you cook it, it should change the protein and you shouldn't react. Somebody on the group asked me about, can I talk more about chicken fish syndrome? And if I'm utterly honest, went, what? No. And so for a start, when someone asks me about allergies and they say something and I think, what? Then because I've been doing this 9 years now and in a specialist centre, then on the whole, it means it's either extraordinarily rare or something from Google. So I did Google what is chicken and fish syndrome. And it's another very similar concept. So some of the proteins in chicken and fish look very similar. So they're saying that some people who are fish allergic may react to chicken. I, in practice, have not seen that. To be honest, poultry allergies and meat allergies themselves are incredibly rare. They're really not common. There's this weird thing that happens with red meat after a tick bite, and we get lots of tick bites here because we're in the New Forest, where people are starting to be reacted to red meat, and that's a bit different. But basically it's saying some of the proteins in chicken and fish look similar, and some people might have symptoms with both. So it's incredibly rare. So, and I've never seen it, and I've not actually seen anyone with a true chicken allergy that I can really think of. And it's the same thing with milk, and it's got a type of protein in called BOS-D4, I think, that also is in beef. But in the European allergy guidelines, they felt that there's no conclusive evidence that people with milk allergies react to beef. But if you look across the group, there are actually quite a lot of people that comment on it. So I don't know. But that's what that is probably about. Oh, we nearly finished because I have to put babies to bed. I'll have to start rounding up, I think. But, oh, thank you, Kathy. There's your other half. Is coconut a fruit? It's a seed, I think. It's definitely not a nut. Neither is pine nut. That's also a seed. Neither is nutmeg. That's a seed. And chestnut is also not a nut. I think coconut is a seed. Correct me if I'm wrong, botanically. Interestingly, Dr. Mish, the allergy consultant at Southampton, did a botanical degree first. So he knows all the Latin names, which is actually quite useful when it comes to allergy, because sometimes, like with peas, for instance, when you know the botanical name, there are other things with the same botanical name that mean you're potentially going to be reactive to all of them. I don't want to learn all the Latin names. They're making my daughter, she's 12, learn Middle English. I mean, what? I don't even know what that is, but she just said, I've just finished my homework. I've translated everything into Middle English. Really? Okay. Anyway, so not sure if it's my asthma, as my peak flow never drops, heart rate normal, chest clear. Okay, well, that's quite interesting, chest clear. It's the mucus going down my nose. You've got dimester, yeah, nasal washes. I know asthma isn't recommended. I think you could be a candidate for immunotherapy, because the key point is that you're sort of, I think it's that almost you're confusing the mix to my simple doctor mind, because you keep going, coming, my asthma's bad. And actually, that's not what you're describing at all, because actually, when you look at it objectively, you've got normal asthma measurements, your chest is completely clear, and what you're describing is here. And therefore, if you are on maximal treatment, which according to the NHS would be a regular steroid nasal spray and antihistamine, for children in Southampton, they also add in Montelukast, but the guidelines say nasal spray and antihistamine, then yes, you are a candidate for immunotherapy. And yes, that should help you. Where you might have your problem is if you're multiply sensitized. So let's say you're allergic to grass pollen, tree pollen, house dust mite mold, then that can be really tricky, because you're maybe not going to get as much benefit as someone who, say, just has a house dust mite allergy. But usually when I'm looking at people, because obviously my allergy work is now private, then we look at, okay, maybe what's the biggest thing? Like, how is this a day-to-day through the whole year, in which case it's probably house dust mite, and can we target that first? Someone asked before about cats and dogs immunotherapy, which again, you can have privately on the NHS in very few circumstances, and it's usually related to occupation, and then we'll consider it. But I'm really always very cautious about doing immunotherapy to cat and dog if you've already got it, because if you're already struggling and then I'm giving you an extra bit of cat, sometimes it's just too much for you. So I do it, but actually I usually put people off, but I would do it, but very mindfully. Thanks, Rachel. Thank you. Steroid, no drops. Yeah, so I definitely think you are a candidate. I enjoy doing these things. It's nice, and it's nice to have a big group asking me lots of different questions. It keeps my brain active. I'm going to try and go and get Gigi to bed, because my kids still all have lots of clubs on Saturday morning, so they still have to get up early. And then they're all really excited because tomorrow they're cleaning, because we make them do that every fortnight that they're all home to earn pocket money. And I'm going to finish some clinic letters, because I've had a few complicated people today, and I know that they would like to see their clinic letters so they can reread it over what I've said. But as ever, I know I don't answer every question, because you can imagine it is quite hard to do that with all my day-to-day, but do pop it in. You know, if you're desperate, just tag me a couple of times and I'll usually come back to it. And obviously remember, if you're really struggling, you've got the membership. I actually have quite a lot of people who have joined. I've sorted it out and they've left within a month, because we've managed to sort the whole problem out, and I'm totally fine with doing that as well. And it's £35, which I think for having a doctor's time for, if I'm honest, they're usually half an hour phone calls, is not bad. But otherwise, I'm here, and we will post the next date that we're here. And remember, if you've got young people and you want to join them with the meetup next week, then I'll share the sign up, or it's probably pinned again, and come and join us on the Wednesday for the live meetup. Obviously it's closed group because we want our teenagers to be protected, but it's at 8:15 and open to anyone, so do come. So Megan, if your daughter wants to come with you and you guys want to share and just feel supported by other people who kind of get it, then do. Yeah, have a good evening everybody, and a very nice weekend. See ya.